Welcome to Dr. CM Edcast, your go-to resource for medical learning. Through discussions, case studies, tutorials, and debates, we help you learn, grow, serve.
All right, in this explainer, we are going to tackle a really critical clinical topic. How do you dose medications safely when a patient's kidneys aren't working well? This is an absolutely fundamental skill for anyone who prescribes medication, so let's get right into it. So let's start with this scenario, one you're going to face all the time in clinical practice. Your patient's kidney function is declining, they definitely need medication, but now you've got a problem. A normal dose might become toxic, but if you adjust it incorrectly, the drug might not even work. This is the tightrope you have to walk, and it's the core challenge we're unpacking today.
You know, to really get a handle on this, it helps to imagine what the perfect drug would look like for someone with kidney disease. It would be a drug that, as you can see here, completely sidesteps the kidneys. It wouldn't be excreted by them, and it wouldn't have any byproducts or metabolites that could build up. But here's the thing. Most drugs are designed to be water-soluble so the kidneys can get rid of them. So a drug this perfect? It's pretty much a unicorn.
Okay, so here's our game plan for today. We're going to start with the problem itself, then we'll dive deep into the why by looking at pharmacokinetics. After that, we'll get practical with how to actually adjust doses, we'll spotlight some high-risk drugs you need to watch out for, and we'll finish up by talking about the extra challenge of managing drugs during dialysis. All right, section 1, the renal dosing problem. At its core, it's pretty simple. When the kidneys can't do their job of clearing a drug or its byproducts, that stuff just builds up in the body. It accumulates. And that's how a perfectly normal therapeutic dose can suddenly become toxic and lead to some really serious side effects.
So that leads us to the big why. Why does this happen? To really understand that, we need to look at how kidney failure throws a wrench into the body's entire drug handling system. And it all comes down to pharmacokinetics, which you can think of with that good old acronym ADME: absorption, distribution, metabolism, and elimination.
Let's start with the A, absorption. This first step really determines a drug's bioavailability. And bioavailability is basically just a fancy way of asking how much of the drug you took actually makes it into your bloodstream to do its job. Now, this is where it gets really interesting because you might be thinking, what does a kidney problem have to do with the gut? Well, it turns out a whole lot. That buildup of toxins we call uremia can make a patient nauseous, it can change how the gut moves, and it can even raise the pH in the stomach, which stops certain drugs from being absorbed properly. On top of that, other meds these patients often take, like phosphate binders, can literally block a drug from getting absorbed. Next up is distribution, the D in ADME. And here, the patient's fluid status is everything. Think of it like this. If you put a drop of food coloring in a giant jug of water versus a small glass, the concentration is going to be totally different. It's the same with drugs. For a patient who is fluid overloaded, a water-soluble drug spreads out into a huge volume, and its concentration can get too low. But in a dehydrated patient, that same dose is stuck in a tiny volume, and its concentration can become dangerously high. Now, this is a really, really important concept, protein binding. A lot of drugs are like passengers on a bus. They travel through the blood attached to proteins like albumin. But here's the key. Only the free drug, the passenger that gets off the bus, is actually active. In renal failure, you often have fewer buses, less protein, and uremic toxins are taking up seats. This means you have way more free, active drug floating around, which can seriously amplify both its good effects and its bad ones.
Okay, onto metabolism, the M. This one's a little counterintuitive because there's more free drug available, there's more for the liver to metabolize. But at the same time, those uremic toxins can actually rev up some of the liver's enzymes, making them break down certain drugs faster. So it's a bit of a mixed and unpredictable situation.
And that brings us to the final letter, E, for elimination. This is, without a doubt, the process that's most directly hammered by kidney failure. The key metric we use is the elimination half-life, and all that means is how long does it take for half the drug to leave the body? The longer the half-life, the longer the drug is sticking around, and the higher the risk of accumulation. So if we zoom into the nephron, the kidney's functional unit, we see that getting a drug out is basically a three-step dance. You've got filtration, where small drugs pass through. You've got active excretion, where pumps push drugs into the urine, and you've got reabsorption. In kidney disease, this whole intricate system just slows way down, which is why that half-life gets longer. Okay, so we've covered the theory, the why, everything goes haywire with ADME. Now let's get practical. Section 3 is all about the how-to. How do we actually take this knowledge and use it to prescribe safely? This right here, this is the golden rule. You need to burn this into your brain. If a drug relies on the kidneys to get out of the body, you have to adjust its maintenance dose. Now, notice that keyword maintenance. The very first dose, what we call the loading dose, that's often the same because it's about filling up the body's volume, not about clearance. But every dose after that needs to be reevaluated. So how do we actually make the adjustment? Well, we have two main levers we can pull. We can either give the same dose, but less often, stretch out the interval, or we can give a smaller dose, but stick to the original schedule. Either way, the goal is exactly the same, to keep the drug level in that sweet spot, preventing it from building up to toxic levels. Right, but to pull those levers correctly, you can't just guess. You need a number. You need to estimate how well the kidneys are actually working. And one of the classic ways we do that is with the Cockcroft-Gault equation. It takes the patient's age, their weight, and their serum creatinine, which is just a muscle waste product that kidneys filter, and it spits out an estimated creatinine clearance. That gives us a concrete number we can use to guide our dosing decisions. Okay, time for section 4. Let's talk red flags. Now, we have to be careful with pretty much all drugs in renal failure, but some are just way more dangerous than others. And if you're studying for an exam, this is where you need to pay extra close attention. These are absolute exam pearls.
This list is your be extra, extra careful list. First, you've got drugs with a narrow therapeutic window, like digoxin and lithium, where the line between helpful and harmful is razor thin. Then you've got the drugs that are almost exclusively gotten rid of by the kidneys, like certain antibiotics. And then the really tricky ones, like morphine, where it's not the drug itself, but its active byproducts that build up and cause major problems.
And here's another key point. It's not just about the drug hanging around for too long. The body itself is different in a uremic state. It responds differently. The brain becomes much more sensitive to things like opiates. The uremia messes with platelets, so the risk of bleeding goes way up. And potassium, oh man, potassium is a big one. The kidneys can't excrete it well, so drugs like ACE inhibitors become much more likely to cause life-threateningly high potassium levels. All right, let's tackle our last section. Just when you thought it was complicated enough, we're going to add dialysis into the mix. For patients whose kidneys have failed completely, dialysis acts like an artificial kidney. And just like a real one, it can pull drugs right out of the blood. So the big question is, which drugs get washed out by a dialysis session? Well, you can actually predict this by looking at a drug's properties. Basically, think about what would fit through a filter, something small, not stuck to proteins, and floating around in the water of the bloodstream. Drugs with those characteristics are highly dialyzable, and this is why you'll often see orders for an extra dose of a medication to be given after a patient's dialysis session. And one last layer of complexity here. Not all dialysis is created equal. You've got hemodialysis with the big external filter, which is generally really efficient at removing drugs. And then you have peritoneal dialysis, which is a much slower, gentler process. They work differently, and they remove drugs differently, so you have to take that into account as well. So what's the big takeaway from all of this? The most important thing to remember is that safe prescribing in renal disease isn't about memorizing endless lists of doses. It's about really, truly understanding the principles of how the body changes. Because for these patients, applying that understanding is everything. It's the difference between therapy and toxicity.